Hi, my name is Alex Reynolds, and welcome to the Hot Topics podcast of the Neurocritical Care Society. Today, I'm excited to introduce Dr. Ariene Lewis, Professor of Neurology and Director of NYU Langone's Division of Neurocritical Care, as well as Dr. Matthew Kirschen, Assistant Professor of Anesthesiology and Critical Care and Associate Director of Pediatric Neurocritical Care at the Children's Hospital of Philadelphia. They were both involved in the newest guidelines on brain death or death by neurologic criteria that was released in early October as a collaboration between the American Academy of Neurology, American Academy of Pediatrics, Child Neurology Society, and Society of Critical Care Medicine. These guidelines now replace the 2010 AAN guideline for adult determination of brain death and the 2011 AAP, CNS, and SCCM guideline for pediatric determination of brain death. And they build on the minimum standards for brain death determination established in the World Brain Death Project. So welcome to both of you, Ariane and Matt.
Thanks.
So I'm really excited to have you guys here because this is a little bit of an insider view on what I'm sure was a very prolonged and tedious process. I'm wondering if one of you can give us a sense of how long it took to generate these newest guidelines and the process that was involved.
So the process actually took a few years, but actually not as long as AAN guidelines have taken in the past. This was actually an expedited version of a guideline process.
Wow. And I think, one of the most notable things about these guidelines is that they've combined the determination of brain death in both adults and pediatrics. Can you sort of comment about what the reason was for combining the two of them?
So the main reason we wanted to combine adults and peds is because really death determination should be independent of age. We realized very on that many of the subtle differences between the adult and pediatric guidelines from 2010 and 2011 were a bit arbitrary and not evidence-based. They were expert consensus opinion. And so we figured that if we got pediatric and adult experts at the table together, reviewed the available evidence, that we could actually come to consensus on many of the things that were similar between adult and pediatric brain death determination. And obviously there's some physiological principles that make some components of the brain death determination process in children and infants different than in adults. But we figured for most of the stuff, it could actually be similar independent of your age.
And some of the differences that previously existed in the prior guidelines just didn't really make any sense. Like, for example, there was a different requirement for the minimum temperature for the evaluation, and the wording regarding the apnea testing target was slightly different, and there wasn't really any physiologic reason for that. So it made sense to be able to combine and into a single guideline for the whole lifespan.
And did you feel that the pediatric group and the adult group sort of seemed to be in agreement for most things, or was there a lot of debate about kind of the smaller details?
I think for the most part, people were in agreement about how to approach brain death, as Ariene said, across the lifespan and independent of age. The mechanism of injury is different in pediatrics than adults. We see more hypoxic ischemic brain injury in pediatrics from either cardiac arrest or shock or respiratory failure, whereas trauma is a bigger component in adults. And one of the things that we had to keep in mind is that infants in particular that have open fontanelles and unfused sutures, that they may not appreciate the consequences of increased intracranial pressure the same as adults. And so they may need slightly longer waiting periods, or different prerequisite conditions to be met prior to undertaking the brain death determination process. I apologize. My office mate is walking in and out as we start.
Sorry about that. Okay. Obviously, he's going to cut that out. Okay. So one of the biggest changes, I think, in terms of terminology is the change in one word, which is the change in the term irreversible into the term permanent for the reason for neurological injury. Can one of you, or maybe both of you, comment on the reason for the change in that specific word?
Yeah, so as you know, this is something different. We do have a description at the beginning of the document that defines kind of why we decided to go with the term permanent. Both terms have often been used interchangeably in the same context or in different contexts. And we chose to use the word permanent to mean specifically that function was lost and will not resume spontaneously, and medical interventions will not be used to attempt restoration of function. There's been an increase in literature related to the difference between these two terms, specifically coming out of from two authors, Andrew McGee and Dale Gardiner. And really, they focus on the fact that when you are using the term irreversible, it suggests that literally anything that hypothetically could be done to try and reverse a situation has been done. And obviously that's not done for either the determination of death by neurologic criteria or the determination of death by circulatory respiratory criteria. And the term permanent was also used by the World Brain Death Project and by the 2023 Canadian Guidelines on Brain Death Determination.
And speaking of the World Brain Death Project, I noticed that there were a lot of new sort of comments on qualifications of examiners, how to demonstrate competence. And I know that this is a guideline primarily for the United States. Do you think this is something that other countries will sort of be commenting on as well?
So that's a good question. You know, the World Brain Death Project was intended to be a establishment of the minimum standards for the determination of death by neurologic criteria around the world, not with the intent for any individual country to fully embrace the World Brain Death Project, but rather to use it as a guide to update their country's guidelines or to create new guidelines in their country if they didn't exist. And so that's the way that we used it. We used it as a foundation, as a sort of a springboard in terms of thought processes related to the revisions when we combine the two guidelines. And going forwards, I think that, you know, the AAN's guidelines have always been cited by many countries around the world. And obviously the AAN is a large international organization. And so I think that it certainly has the potential for other countries to embrace this guideline, as has been the case previously. When looking at international protocols for the determination of death by neurologic criteria, there were a few countries that indicated that they use the AAN guidelines as their national standards. And so I anticipate that that will continue to be the case going forwards now.
I want to make sure that I sort of make it clear before we keep going that we're not going to use this podcast to sort of go through the nitty-gritty of changes between the old guidelines and the new. I would encourage people to look at the neurology clinical practice paper that both of you wrote with David Greer that sort of highlights, I think, very nicely the changes and the additions. And I would also encourage everyone to read the actual guidelines, tedious as it may be, because I think this is really important stuff. And I think we're going to need to get our hospitals potentially up to speed on some of the changes that have been made, both in terms of the sort of criteria for that you must sort of pass in order to declare death by neurologic criteria, but also the specifics of, you know, prerequisites to brain death determination and ancillary testing. And we will kind of highlight a few of those things, but I do want to encourage the readers to kind of go back and read everything themselves. And I also want to highlight that one of my favorite parts was the e-tables that come with the guidelines, mostly because and I'm sure the pharmacists are going to salivate over e-table number 2. But I thought it was great that you guys included sort of a pharmacokinetic table for medications that depress the central nervous system. And you specifically mentioned, you mentioned that pentobarbital levels should just not be detectable at all, and that other medication levels should really be within the therapeutic or subtherapeutic range. And I'm sort of wondering, is that something that you went in sort of feeling was a deficit in the previous iterations of guidelines? And how did you get pharmacy to sort of our pharmacist colleagues to weigh in and help with that?
So
Go ahead,
Ariene.
Part of the thought process in writing the new guidelines was that we wanted to ensure that we were addressing the many questions that have come up towards us in the past about the prior guidelines. And so one area of questions has been related to testing after administration of drugs and how long it's necessary to wait. Another area that's come up is questions about electrolytes and other laboratory values and whether certain specific derangements are acceptable or unacceptable with the evaluation process. So with that in mind, we did create two tables that address this issue. First, as you mentioned, the pharmacokinetics table, which was created in conjunction, Matt created in conjunction with a PharmD at his institution. And then second is the table of suggested metabolic values prior to the evaluation, recognizing that there's no scientific evidence that, for example, a sodium of 161 is unacceptable, but a sodium of 159 is acceptable. But we actually took information based upon a survey study that David Lerner had done a couple of years ago of members of NCS about their perspectives as to acceptable and unacceptable lab values when doing the evaluation, and incorporated that into this table so that there were some recommendations on this topic.
One of the other reasons why I think those tables are so important is because we really wanted to emphasize that determination of brain death is really a clinical determination. And we wanted to give people all of the tools available so that they could go through all of their prerequisites, exclude all potential confounders, and proceed with the clinical examination preferentially rather than use ancillary testing. We really tried to narrow the indications for ancillary testing such that if you could correct an electrolyte abnormality, if you could wait longer for a medication to be metabolized and cleared from the body, that was really the preferred way to make a clinical determination of brain death. And we wanted to give people as many tools as possible in order to be able to do that effectively.
So that's a great point. And I think, having read through, and especially, specifics about how long to wait after a cardiac arrest, how long to wait after cooling, I think some people may feel that brain death determination is going to be sort of delayed, and that things are going to take longer before you can, sort of clinically diagnose. And I wonder what your response would be to people who sort of are unhappy with having to wait a little longer.
We're more than okay with their unhappiness about that. The goal in the evaluation process and writing the guidelines was to be as conservative as possible. Nobody ever wants to find themselves in a circumstance where they've made a determination of death and then they have to subsequently go back and say, whoops, I made a mistake. So the goal in creating the guidelines was to ensure that as much conservatism as possible was being employed throughout all aspects of the determination process.
And that's also why I don't like the word delay. We are not delaying the determination of death. We are advocating for an appropriate observation period to determine permanency and irreversibility of the brain injury. And we have lengthened that period of time for some specific etiologies like hypoxic ischemic brain injury and in younger infants and children in particular. But one of the other things that we emphasized is if the patient undergoes an intervention in order to try to promote neurorecovery or neuroprotection, if they were treated with therapeutic hypothermia, if they had medical or surgical interventions to lower ICP, then we advocated that you actually need to give time to see if those interventions were effective. So you can't give a dose of hypertonic saline and then proceed to your brain death evaluation. You need to give your hypertonic saline, give it an appropriate period of time to see whether it was effective or not, and did the patient have any recovery of neurologic function, and then proceed with your brain death evaluation. So we don't consider it delaying the evaluation. We consider it observing the patient for an appropriate period of time to ensure the permanency of the injury. And once you have done that, then proceed with your clinical evaluation.
The message that we always reinforce when we're teaching classes about brain death determination is that it should never be a rush to make a determination of death.
I think that's a great way of framing it. And, obviously there are societal concerns about the idea of brain death and suspicions. And so I think that, there's nothing more permanent than the declaration of death. So we should be 100% certain when we're doing it. I did want to talk a little bit about ancillary testing, because I do know, one, that ancillary testing sometimes is used to sort of bypass the clinical test. But also there was a very important change in use of ancillary testing. So EEG has now been taken out as an appropriate ancillary test. And I think most people would probably agree that technically it's very challenging to do an EEG as an ancillary test without any what's the word? Technically, it's very yes. Technically, it's very challenging to do an EEG in an ICU without any artifacts and get an appropriate result that would be consistent. But I'm wondering, what were the other conversations surrounding removing EEG as an ancillary test?
Yeah, so first, we really wanted to ensure in describing the purpose for ancillary testing that we were very clear that ancillary testing should not be used as a replacement for the clinical evaluation, and that first and foremost, brain death determination is a clinical determination, and all portions of the evaluation that can be completed, including the apnea test, must be completed before thinking about going towards ancillary testing. In terms of the specific tests that were noted to be acceptable tests, as you mentioned, the EEG has now fallen out of favor and now is no longer included as an acceptable test in the guidelines. And similarly, this is the case in the World Brain Death Project and also in the Canadian guidelines. And while, as you mentioned, there has the potential for artifact in the ICU environment, that actually wasn't really the main factor that contributed to eliminating this as an ancillary test. Rather, the concern is that an EEG does not evaluate brainstem activity. And when it comes down to it, much of the evaluation for brain death determination involves the evaluation for brainstem reflexes and also the ability to breathe spontaneously, which is coming from the brainstem. And so therefore, if we're just evaluating the cortex with our ancillary test, then that's not really a suitable ancillary test.
And speaking of the apnea test, I do think it's remarkable that you all commented specifically on obtaining consent for evaluation of death by neurologic criteria. And I imagine in pediatrics it's probably even harder than in adults, but I wonder if either or both of you wanted to comment a little bit about the reason for specifically putting that in.
So first, just for clarification in terms of what the guidance is that it's not necessary to obtain consent prior to the evaluation, that all efforts should be made to notify a family of the intent to perform a brain death evaluation, but it's not necessary to seek consent. And this is consistent with guidance that was put forth previously by Ariene in a position statement a couple of years ago that focuses on accommodation or how to accommodate or whether to accommodate objections to the determination of death by neurologic criteria. So we wanted to reinforce that message that consent is not required, particularly because this is something that's been kind of highly debated in the literature. But over 3/4 of neurologists indicate that in surveys that they do not obtain consent, that they do not think consent should be needed. And so we just wanted to really clarify that for sure in the guidelines themselves.
And thank you for clarifying exactly what I meant by the consent issue. I think one of the other sort of interesting inclusions, which had been sort of spoken about a little bit in the World Brain Death Project, is the inclusion of patients who are on ECMO. And I'm sure that there was a recognition that patients are increasingly placed on ECMO with resultant catastrophic neurological injury. What was the discussion in terms of performing apnea testing on ECMO? And was there much of a debate, or was it pretty sort of well established what the guidelines were going to be? Matt, you're muted.
Sorry, I was trying to cut out background noise. So prior to producing these guidelines, there were several institutions that had published their protocol for how to do apnea testing on ECMO. And from a physiologic standpoint, it is not different to do apnea testing on ECMO than it is off of ECMO. The same principles are followed, where you normalize the pH and the PaCO2 prior to beginning. You pre-oxygenate the patient. And in the case of being on ECMO, you would pre-oxygenate both through the ventilator and through the ECMO circuit. And then when you are going to begin the apnea test, you're following the same procedure as you do when the patient is not on ECMO, that you remove the patient from intermittent mechanical ventilation. And then during that time, you need to provide apneic oxygenation. So there are multiple different ways to do that, some that are preferred in pediatrics because of their limited pulmonary reserve. And you actually have an advantage on ECMO that you can actually provide apneic oxygenation through the ECMO circuit, which may provide a margin of safety. And then you have to allow time for the CO2 to rise to stimulate the medullary chemoreceptors to see if you have any respiratory effort. When you are not on ECMO, simply taking the patient off the ventilator, if the patient is not having spontaneous respirations, will allow the CO2 to rise. When you are on ECMO, you need to decrease the sweep flow, usually to somewhere between 0.5 and 1 in order to allow the CO2 to rise. Sometimes after doing that, you do not get adequate CO2 rise because of the efficiency of the membranes that are now used for ECMO. So sometimes CO2 needs to be added into the circuit in order to get it to rise to the appropriate level. The other thing that needs to be kept in mind when you are on VA ECMO in particular is where you sample your blood gases from, because you actually want the CO2 that is being seen in the cerebral circulation rather than in the systemic circulation. And if you have native myocardial output and you have ECMO flow, depending on where your ECMO cannula is, then the blood going to the brain is going to be some mixture of the blood from the native myocardium as well as from the ECMO flow. And so in order to best estimate what CO2 is being seen in the cerebral arterial circulation, then you have to check blood gases from both the ECMO circuit post-oxygenator and from the patient's arterial line. And where the patient's arterial line is relative to the ECMO cannula needs to be taken into consideration so that you best approximate the CO2 in the cerebral circulation.
I love the specificity and the detail, and it sounds like I'm.
Alex, hold on 1 second. We have crazy feedback, but I don't know where it's from. Is that from you, Ariene?
No, I can't figure it out. Hold on. Sorry, Alex.
No, that's totally cool. What was the last thing you guys heard? I sort of
you said that you said you were talking about the specificity.
Yeah.
Oh, okay, cool. Okay, so I'll just start over from there. I saw all you guys smiling and I was like, I can't possibly be saying anything that funny.
Oh, actually, I was smiling at what you were saying.
Okay.
And then the sound started.
and then you were just making fun of me. Got it. So we'll start over after Matt says his thing. And I'm going to say, I do love the amount of detail and the specificity that went into not only describing how to do the apnea test and apnea testing on ECMO, but even the clinical exam. And I think that sort of specificity, even though it can be challenging to read, is important for ensuring that everyone's sort of doing this the same way. So I appreciate that. And I wonder sort of how might we ensure that hospitals are going to be in compliance with these new guidelines? Was there any discussion about that?
Yeah, so that's a great question. As you alluded to earlier, it's incredibly important that everyone who listens to this podcast, everybody who reads the guidelines, will go back to their own guidelines in their hospital and update them to be in accord with the new guidelines. As we've seen from prior studies looking at hospital protocols on the determination of death, we see that there is variability from hospital to hospital and that there's variability in comparison to the accepted guidelines. And so we're hoping that with these new guidelines, that everyone will be more proactive about reviewing their hospital standards in more detail to ensure that they are consistent. In terms of any sort of regulation to ensure that hospital protocols are in line with the new guidelines, we have been discussing getting JCAHO involved to see if there is the ability to provide some oversight in that capacity, but that's not something that's in place as of yet.
One of the things that was in our mind as we composed the document for the guideline itself was to try to make it as easy as possible for institutions to adopt these guidelines. The ancillary tables were designed in a way that hopefully they can just be included in hospital protocols. In addition, one of the other appendices to the document was a checklist that institutions could either use as is or could adopt into a smart phrase to be used in their electronic medical record system. The other thing that I will note is on the AAN website, there is a digital interactive tool that will actually, for an individual patient, take you through the flow chart or the path of how to do a brain death determination for that individual patient. It will take you through all of the prerequisites, through the exams. It will give you the questions to indicate whether the patient needs an ancillary test. It will give you the option of doing 2 exams for adults, the mandated 2 exams with the waiting period for children, and then advise you on the time of death determination at the end. So that is a very valuable tool that people can use on their own personal device at the bedside in order to guide them through doing a brain death determination.
Yeah, that was really incredible to go through. And for those of us who are maybe not as tech savvy, there is also a printable criteria checklist in one of the appendices if you're more used to checking things with pen and paper. On a related note, I know that the Uniform Law Commission was looking to make some updates on the Uniform Determination of Death Act, or the UDDA. Where are we with that, and how does this fit in?
Yeah, so that's been a 3-year process to try and revise the UDDA because of a number of different concerns with the language of the UDDA that I won't get into here, but are addressed in a couple of publications I've had in neurocritical care. But most recently, there was a drafting committee to discuss specific textual revisions to the UDDA. And after the drafting committee met for 2 years to discuss revisions, this summer, those revisions were brought before the full Uniform Law Commission in a meeting in Hawaii to talk about both those specific revisions and the general concept of revising the UDDA further. And after that meeting, it was ultimately determined by the Uniform Law Commission that at present, this issue is too controversial in terms of what language should be employed in the revisions. And therefore, we are now in a pause, which I'm considering an indefinite pause to the drafting process. I do have a paper in Neurocritical Care that addresses comments that the ULC received from medical societies, from organ procurement organizations, and from advocacy organizations that addresses the textual thematic content of these comments in terms of what they would like to see versus what they would not like to see in a UDDA revision. And in reading the paper, you'll see that, there's a lot of different perspectives from these different stakeholders. And this is what contributed to the ULC deciding to table this issue.
Wow. So even more reading for our listeners. Check out Dr. Lewis's latest in neurocritical care. Is there anything else that we haven't really talked about that you think is important to emphasize?
No, I think you've really covered it. Thank you so much for having us on. And I think, as you reiterated, it's important to ensure that everybody goes back and reads the guidelines, reads the comparison document, and then reviews their institutional protocols and updates it accordingly.
Thanks to both of you and everyone else who was on the committee who spent years trying to update this. And thanks a lot for your time coming on the podcast today. Just remember, everyone, you can access the NCS podcast wherever you get your pods. Add us to your favorites and be sure never to miss an episode. NCS also offers free continuing education credits for listening to select episodes. Listen via the NCS Learning Center and complete a short survey to receive your free credits. Thanks, everyone, and see you next time. Cut. All right, great. Thank you guys so much. This was really interesting.
Thanks,
Hey,
Alex.
The answer I gave at the very beginning about the peds thing, where I like stumbled a little bit at the end because I didn't want to bring up some of the differences. Will you just make sure that sounds okay when they edit it?
Yeah. He usually lets me listen to it before we release it. And I'll let you guys know when we release it, or like the day before we release it or something. Because I'm sure.
All right. I just want to make sure I don't say it doesn't come out egregiously bad.
I thought what you said was fine, though.
Okay.
I thought it was great. But I'm happy. I don't know anything about children, so you could say all sorts of things and I wouldn't know the difference. Awesome. Thank you guys so much. I know this is like a ton of your time. I really appreciate it. And yeah.
No problem. We're happy to highlight the new guidelines.
Cool.
Thanks, Alex.
Awesome.
Thanks. Have a
Thanks.
good day.
You too.
Bye-bye.
Bye.